Without further ado, and sorry for the delays, I'm going to hand it over to my colleagues, Sarah and Michelle, to go ahead and get started. Thank you.
Hey, thanks everyone. Thank you very much to Jason and to Yassine, and thank you to everyone who's joining us across the globe. It is bright and early here in Washington, D.C., where I'm joining. This is Sarah Bradley, and I know that many of you are joining some very late hours from Asia, so thank you all very much. I'm Sarah Bradley, and I am, okay, I can hear that from some of you that my voice is not clear. I hope that's a little bit better, but if it doesn't get better, please do let me know. I appreciate it. And as Jason mentioned, you can send a message in the chat box at any time. Next slide. Thanks. So I'm Sarah, and Michelle and I both work for the SHOPSPlus project, which is sustaining health outcomes through the private sector. It's USAID's flagship initiative in private sector health, led by APT Associates. And our goal is to improve outcomes in maternal and child health, HIV, tuberculosis, and what we'll be focusing on today is our work to expand access and choice contraception through this strategic expansion of private sector approaches in the health system. Next slide, please. So I probably don't need to convince any of you on this call today, yeah, I'm seeing that there's still some volume issues. Yassine and Jason, I appreciate any help you're able to provide.
So, as I was starting to say, now more than ever, understanding where women access their contraception really matters. Since the beginning of FP2020 in 2012, we've seen substantial growth in the modern contraceptive prevalence rate, or MCPR, and changes in method mix that really affect where women are accessing their contraceptive sources. We know that especially now, it's really important to understand where women are accessing their contraception, because that can help policies and programs and sectors work together to create flexible solutions that respond to new and evolving COVID-19 constraints and other health shocks. For example, right now, we know that many women, millions of women, in fact, around the globe are facing reduced access to contraception. And they're having to switch to be able to safely access contraceptive methods that don't require direct contact with a healthcare provider, right? So instead of relying on injectables and implants, which can't be done safely under social distancing guidelines, they're relying more on self-care methods like pills and condoms, which are accessed from very different kinds of sources. We also need the public and private sectors to be able to continue to collaborate to improve contraceptive access, contraceptive choice, and equity, and work towards a sustainable contraceptive future. Next slide, please. So as I mentioned, I'm Sarah Bradley. I'm going to give a quick overview of the private sector counts tool. Michelle Weinberger will then give us an overview of FPMarket Analyzer. And as Jason and Yassine mentioned, we should have plenty of time for your questions. So please enter those in the chat box at any time. Next slide. I want to briefly explain how these two tools work together and then jump into private sector counts. These are two interactive data visualization tools, and they both provide information on sources of modern contraception from two complementary angles. Private sector counts, which we'll talk about first, shows us where we are today and where we've been in the recent past. FPMarket Analyzer, which we'll talk about second, helps us visualize where we could go in the future. Next. So before we jump into private sector counts, I just want to give you a little bit of background about the name. Under SHOPS, our predecessor project, we found that people actually needed to be reminded that the private sector is a key partner in providing family planning in low and middle income countries. We know now that it serves 1 out of every 3 modern contraceptive users, and so the tool was named Private Sector Counts to remind our global audience that the private sector does indeed count in terms of providing women their contraceptive supplies and services. Next slide. So you can use private sector counts to help policymakers and program managers understand where women get their contraception, broken down by key social and demographic characteristics. So it helps us to look at distinct population segments when we're designing programs and policies. In private sector counts, you can compare results by country, by urban and rural residents, by contraceptive method and socioeconomic status, and by women's age and their marital status. Next. We've updated all the data on private sector counts with the most recent demographic and health survey data, or DHS data, in 36 countries. We included every FP2020 priority country that's had a demographic and health survey since 2012. Next. And in DHS surveys, when women who report that they're using a modern method of contraception, they're asked where they got that method the last time. And they can answer in a variety of ways, and those are listed on the right-hand side of this table here. There's also several country-specific options, and we worked with country stakeholders to standardize those different sources into the categories that you see on the left. So we've categorized them into these multiple private sector sources that are in dark blue that we'll break down in later slides, public sector in light blue, and we've used these colors to consistently represent private and public sector across the two tools for consistency. And there is a small percentage of women who report that they got their method from a friend or a partner. This is usually women who are using condoms and report that they got their method from their husband or partner. And we can't really categorize those into private or public sector. So those are going to be shown in gray in the visualizations that we'll show in just a moment. Next. In private sector counts, we look at contraceptive sources 3 different ways. First, to get the big picture, we look at contraceptive sources among all women of reproductive age, so we can see the contributions that the different sectors make to achieving the modern contraceptive prevalence rate, or MCPR. Second, we look just among modern method users, so we can see where the users are going for their methods. And then narrowing in again, we just look at women who go to the private sector. Are they getting their method from a private clinic, from a pharmacy, a shop, or a non-governmental organization? Next. So this is the home site to private sector counts. It's privatesectorcounts.org, and as you'll see at the top of the slide, you're welcome to access the tool now and follow along live as I go through this demonstration. As you can see, when you get to the home page here, we have a whole side of the site that's dedicated to child health and shows similarly sources for sick child care on the left. We're going to focus today on the family planning side on the right. So if I click on the family planning banner, we get to the first visualization. Next, please. So this takes us to the first group we discussed. This graph shows sources among all women of reproductive age. So each bar sums to the country's modern contraceptive prevalence rate. So for example, we see that the MCPR is 20% in Liberia among all women, all the way down to 4% in Chad. And we're just looking here at the West and Central African countries. The private sector is shown first in dark blue, and then public in light blue. And if you hover over any bar, you can see the details. Next, please. Next. So if you hover over any of the bars, you can see the details, including that 13% of all women in Liberia get a modern contraceptive method from the public sector. And you can see all of those details when you hover. Next, if we click on the right here on Explore Sources Among Modern Contraceptive Users, we should switch to the next set of visualizations. Next. So now we're looking at sources just among contraceptive users. So these bars sum to 100%. And the data are organized, as you can see, by region on the left, and then by country on the left-hand side. Next, if we go to the third set of visualizations at the bottom, that is going to allow us to look just at the dark blue portion of the bar and zoom that out to 100%, so we can look at where women are going within the private sector. Next, please. So if we click there, that brings us to this graph, which shows us the 4 different types of private sector sources that I outlined earlier. In dark blue, we see the percentage of women going to the private sector who get their method from a private pharmacy or drug shop. In light blue, that's women who are going to general stores or markets. Light purple shows the percent going to private clinical sources, and dark purple shows the percent getting their method from a non-governmental or faith-based organization. Next. So now I want to show you the drop-down menus, these interactive navigation menus, and this is the really fun part of the site, where you get to play with the data and examine whatever is interesting you. So as you can see here, we have this drop-down menu, and right now we've selected all countries, all methods, and we're looking at the total population, but we can change that. Next. So under country, next please, we right now have all countries selected, but we can check a single country or any combination of countries. Next. Right now, we're looking at all modern methods together, which is what's checked here, but you can select any method or group of methods. So if we select pills, the graph changes. Next. So now we're looking at the same graph, but sources just among pill users. And as we expect, many more women are getting their pills from private sector sources in dark blue. Next. Right now, we're just looking at the most recent DHS survey, but we have 2 DHS surveys for each country that has 2 recent data points. So if you want to compare changes over time, you can select both most recent and previous, which will take you to this graph. Next. So that shows 2 surveys for every country that's had 2 DHSs. So for example, if you look at the top 2 bars in Indonesia at the top of the screen, we can see how sources for pills have shifted between 2012 and 2017. So the proportion of women getting pills from private sector sources has increased over the most recent 5 years shown. Next, please. Lastly, you can disaggregate the data by a number of demographic characteristics, which is a key part of the tool because this helps us better understand these distinct population segments. So we can disaggregate based on socioeconomic status, as you can see, place of residence, age, and marital status. Next. So for example, if you select by wealth quintile, we can see this graph, which shows how source patterns are different for users in each quintile. So if we look at Benin, which is the second set of bars here, we can see that going from the poorest wealth quintile to the wealthiest, the proportion of women who are getting their method from the private sector increases as the wealth quintile increases in a stepwise fashion. Next. So for any of these visualizations, you can click the download button, which is at the bottom of the screen, shown in the icon with the yellow arrow. That's going to allow you to download the image file or the data in a spreadsheet for your own calculations or to make your own visualizations. Next. So I've just shown you the tool, which is fun and interesting to play with the data, especially if you're a nerd like me. But how are we actually going to use private sector counts for family planning programs in specific countries? So let me give you just a couple of examples of how we've used the tool. So country teams have been using private sector counts data in a variety of ways. First, to understand the landscape. What roles are the various sectors playing in the country, and how does that vary by contraceptive method and characteristics? As I mentioned earlier, many health programs tend to focus kind of strictly on public sector sources, and it's sometimes really important to remind them that many, many women, potentially an increasing number of women, are getting their method from private sector sources as well. So that's important to consider in policy and programming. Next, second, other countries have looked at recent trends in their country, particularly how source patterns have changed as method mix has changed in several countries. In most cases, that's an increasing proportion of women who are using implants and injectables. And third, to look across countries. So for example, when we were working in Senegal with our team there, we see that private sector pill provision is low in that country. So we were able to compare Senegal to other Francophone countries that have similar policy and regulatory barriers to accessing pills over the counter and in pharmacies. Next. So that was a very quick overview of private sector counts. And I'm now going to turn it over to Michelle so you can see how the tools work together as Michelle introduces Family Planning Market Analyzer. Next, and Michelle, the floor is yours.
Great, thanks so much, Sarah. My name is Michelle Weinberger and I work with Avenir Health and we're a partner on the SHOPSPlus project. And I'm going to talk to you a bit about the FPMarket Analyzer. So as you just heard from Sarah, this tool complements private sector counts by allowing us to take a deeper dive into countries and to also look at future changes. Next. The FPMarket Analyzer is an interactive web-based tool that brings together a couple different data sources. So first, we look at method mix and source mix from the most recent demographic health survey in each country. So this draws on the data that Sarah just presented within private sector counts. And then we combine this data with projections of contraceptive prevalence, women of reproductive age, and the number of modern method users, drawing from estimates from FP2020, Track 20, and the UN Population Division. We also bring in some data from the World Bank on poverty headcounts, which we'll talk a bit more about at the end of this presentation. The tool lets you do two different things. First is get a view of the current situation. Here, I'll note that our current situation is looking at an estimate for 2020. So we're taking our estimated number of users in 2020 and distributing them by method and source based on the most recent DHS in the country. And then we look at some short-term scenarios for projecting changes out over the coming 3 years. Next. So back a few years ago, SHOPSPlus put together two briefs to look at the potential role of the private sector in achieving FP2020 goals. These briefs explored a range of different hypothetical scenarios, such as what is the potential if the private sector was able to increase its share of injectable provision through task sharing, or what might it look like if the private sector increased its provision of long-acting methods such as IUDs and implants. These briefs were very useful as advocacy materials, but they were only looking at a global level with a little bit of regional disaggregation. And so the FPMarket Analyzer was built to really take the idea behind those briefs, but let you explore for an individual country, and also to make the scenarios customizable so that you could start by looking at similar scenarios to what was presented in the brief, but be able to change them to meet the needs of your own country and the discussions that are happening there. Next. So why do we need this tool? I find often when we're talking about total market approaches, we have very theoretical discussions about making changes to the role of the public sector or the role of the private sector. But it can be hard to quickly translate these into what it would actually mean in terms of shifts in where women go, what it would mean for method needs. And so the FPMarket Analyzer is designed to do just this. So let's walk through an example. So what if in a country you were talking about what are the potential implications of increasing the use of the private sector for family planning in urban areas? So we can look at this from three different perspectives. First, as you see in that first box at the bottom, there's sort of a compositional question. How would that change in urban areas change the national picture? In a country where most women live in rural areas, even a big change in the urban areas isn't going to have a huge impact on the overall picture. And so the tool lets us think about how changes among different segments might influence the national picture. Next is a feasibility question. The tool can show us things like how many more clients the private sector would need to serve, And then countries can look and think about the feasibility of this change relative to the number of private providers that already exist, and think about what plans would need to be in place to make that change practical. And then finally, we can look at questions around method choice. As we saw in the data that Sarah presented, in many countries, the private sector primarily provides pills and condoms and other short-term methods. And so if we had a big shift towards women going to the private sector, we want to look at what that would mean for what methods they're using and what can be done to ensure that women continue to have access to a full range of different methods. Next. The tool itself is structured into modules. So we're going to take a deep dive into these first two that look at a sort of current national landscape, which is an overview of the world now, again, looking at projections or estimates for 2020. And then our policy scenarios, which lets us explore different things that could happen into the future. And then at the end, I'll come back and talk about these remaining modules, which let us look at the market among some different key segments. Next. The tool can be accessed at FPMarketAnalyzer.org. Like with Sarah, if you want to go there now and follow along, you're welcome to, or have a look after we're done on the webinar today. So the first thing that you'll need to do is select your country. We're looking now at Afghanistan. The countries are in alphabetical order, so that is the country that comes up first, but you can select from nearly 60 different countries from this list. And then second, you'll see the navigation panel on the left there that follows those modules that I just talked about. So if you click on the current national landscape, we'll take a look at that on the next slide. So here we're looking at the current national landscape. The first thing we want to look at is this graph at the top, which shows us the projection in modern contraceptive prevalence, or MCPR, among all women. This data is aligned to the latest FP2020 progress report and shows us a little bit about where the country has come from in recent years. All of the results that we look at, both for 2020 and our projections, are accounting for two different things. They're accounting for changes in contraceptive prevalence over time, as well as changes in the number of women of reproductive age. And so as we look to the future, we're accounting for the fact that we don't live in static places, but that the number of users is increasing. And so all of our scenarios account not only for the changes that we look at in terms of source mix and method mix, but also for the fact that there'll just be more women using modern contraception in 3 years' time than there are today. And so now next, let's zoom in a little bit more to this next section. I just want to point out a few things. So first, you'll see throughout the tool, there's text probing key questions. This way, when you're looking at the data, it's giving you some context of what to think about. This can be helpful also if you're working through this tool with partners or decision makers to help inform what kind of discussions to have. So this first graph that we see looks at the overall source mix between public, private, and other, again, using the same colors and categorization that Sarah described for private sector counts. Here we see in Afghanistan that there's a pretty even split between those going to the public sector and those going to the private sector. The next graph then shows us this information, but in terms of the absolute number of users by method. So in this graph, the height of each bar shows the total number of women using that method, and then the colors in the bar show the relative split between the different sectors. So here we can see that across each method, we have very different roles of the public and private sector. And we can also see the importance of looking at this information in both relative terms, in terms of percents, as well as absolute terms in terms of user numbers. So if you look at those two highlighted sections, we see that in relative terms, a higher share of condom users, 66%, get their condoms from the private sector than pill users. So 62% of pill users get their condoms from the private sector. But because there are just so many more pill users than condom users in the country, in absolute terms, pill users make up a much larger number of private sector users. And so thinking about this data in both of these ways helps us get a better understanding of where women are going. Next. Before we move on, I just want to show a few features of the tool. So you can hover on any of the graphs and get additional detailed information. And also all of the graphs can be downloaded either as images or as data files so that you can play with the data yourself in Excel and make your own graphs. Next. So that was a quick overview of the current snapshot. There's some more data there that we don't have time to look at today, but I encourage you to go and have a look. And now we're going to take a quick look at looking to the future and projections. So there's 3 different pathways to get to future changes. So first we can look at changes in method mix. So if we change the method mix in a country without changing where women go for those methods, we're likely going to see a change to the overall source mix. So for example, if there's a method that's mainly accessed from the public sector and that method increases its share, then so too will the public share increase. Similarly, if we change the source mix in a country without any changes to what methods that women get from those sources, we'd also see changes in the method mix. So for example, if the role of the private sector is increased in a country where the private sector mostly just provides pills and condoms, we'd expect to see more women overall using pills and condoms in the method mix. And then finally, we can change both of these together to explore how the 2 different changes could influence each other. Next. Across all these different scenarios, we're going to look at some similar cross-cutting considerations, such as how many users will be impacted by the change, how will the change influence the overall picture, and what will it mean for each sector? How many more or fewer users or visits will there be? Next. So within the tool, we've created a policy scenario generator where we have 4 pre-made scenarios to look at. So the first scenario says, what if we don't make any changes? We just maintain everything, but just see what we need to do to keep up with the growth in the number of modern method users. The second scenario explores task sharing that would allow more injectable provision through the private scenario. And scenarios 3 and 4 both look at what would happen if we saw more use of LARCs and more use of LARCs as well as an increased role of the private sector in providing those methods. So we're going to take a look today at scenario 4, and just to note that we're now looking at Kenya, as you can see from that country select box at the top. Next. So these scenarios are automatically created for you, but I just wanted to show you a peek behind the scenes of what's actually happening when you select scenario 4. So when you select this scenario, 2 different things are automated. First, the use of implants doubles. So we see here in Kenya, implant use would go from about 18% to 36% of the method mix. And then we also increase the share of users going to the private sector by 20 percentage points. So again, for these pre-created scenarios, these changes are all created automatically, but there's also a build your own scenario feature where you could edit these changes to make them customized to anything that you want to look at. Next. So now let's have a quick look at the results. So again, here we're looking at a scenario where LARC use increased in the country and the private sector played a greater role in providing those methods. Overall, we see not a huge change in the source mix, going from 39% of users getting their method from the private sector to 43% of users under our new scenario. So it seemed like we made some pretty big changes, but we're not seeing huge changes here. So let's look in more detail to see why. So first, we find that even with our changes, more than half of women are still getting their implants from the public sector, so it's still playing a big, important role. We also see that with our increase in LARCs, that led to some declines in short-term method users, which you can see those pills and condom numbers going down, as well as injectables. And since many of those women got those methods from the private sector, that kind of led to some declines in private sector users. And then finally, we see that despite our big increase in implants, that injectables still continue to be a very dominant method, and that a lot of injectable users get their method from the public sector. So we still have a fairly large base of public sector injectable users in the country. And so we can see all these different dynamics of why that change is happening. So we don't have time to look today, but if you kept scrolling down in the tool, there's a lot more detailed results available, including looking at changes in the number of visits, as well as in the number of commodities that can be helpful in planning and in having more detailed discussions with partners and policymakers. Next. So these last three modules take a similar approach, but look at changes among key segments. So the first lets you look at changes by age and marital status. The second lets you look at changes in urban versus rural areas. And the third lets you look at changes by income level. For each of these modules, similar to what we just looked at, there's first a review of the current situation, looking at a projection for 2020, and then you can explore future scenarios where you make changes to the source mix for one of these different segments. We don't have time to look at this in detail today, but I wanted to just take a quick look at the income level results, since these are pretty new to many in our community. Next. Next slide, please. Next slide. Great, thanks. So typically with the DHS, we look at things by wealth quintiles. And what wealth quintiles do is they take the whole population of a country and they divide it up into 5 equally sized shares. So we call this a relative measure because it's based on the poorest versus the richest compared to each other within a country. Relative measures like this can be really helpful for understanding equity and thinking about differences between different groups of women or of different people within a population. But we also think, especially when thinking about total market approaches and the role of the private sector, that it can also be important to look at absolute poverty or absolute income. Here we're looking at using poverty lines. So in this example, we take a country where half the population lives below the international poverty line, which is defined as living on less than $1.90 per day. So we can see that rather than having these 5 different increments that are evenly divided, we would end up having half of the population living below our international poverty line and half living above. So for our tool, we actually use 4 different poverty lines. We use the international poverty line of $1.90 per day, and then 3 other poverty lines based on poverty lines for lower and lower middle and upper middle income countries. If we go to the next slide, we can have a look at what this looks like. So here we're looking at examples for 2 low-income countries, Burundi and Haiti. So here, like before, the height of the bar represents the total number of modern users, and the colors show us how they divide across the public versus the private sector. That first bar is our bar of users who are living in extreme poverty below $1.90 per day. So the first thing that we can think about is how many women fall into each segment. This is determined by 2 different things. It's determined by the number of women who are in each of these different segments within a country and the level of contraceptive use within each segment. While quintiles, we see some differences, we tend to get a more even distribution, again, because that starting population is evenly distributed across the quintiles. Whereas here, we see very contrasting and different pictures when we look at this by income. We see almost all users in Burundi are living below $1.90 a day, since a large share of that country is living in extreme poverty. And we contrast that to Haiti, which again is also classified as a low-income country, but has a very different distribution of its users of contraception, with a somewhat even share falling across each of these different income levels. And then secondly, we can look at the role of sector by each segment. And we often, as we see in both of these examples, see an increasing role of the private sector in each of these different income segments. So it's a little hard to see in Burundi because the segments are so small, but the role of the private sector increases from 12% to 34%. And in Haiti, we see a little bit less variation, but still an increase. So 42% of those living on less than $1.90 a day go to the private sector, and 51% of those living on more than $550 a day go to the private sector. It's important to remember that living above these different income thresholds doesn't necessarily mean women are rich or that they have the ability to pay for family planning. But we think using this absolute lens can bring some additional perspective that can be missed when just looking at wealth quintiles. And so we think it's a helpful way to also think about how to segment when thinking about the roles of the public and private sector. Next. So just to summarize, we think this tool is really helpful, and we've seen it used in countries to help inform TMA discussions and support TMA advocacy efforts to talk about the important role that both sectors are playing and how those could change looking to the future. And then it's also really helpful to provide these sense checks to make sure that what's being talked about really makes sense. So on one end, we've seen that if you make a big change, but to a pretty small segment, that change might not have the impact that people are expecting it to. But on the other hand, making a big change to a very large segment might not be feasible. And so the tool helps to think about what those changes actually mean, and are those changes meeting expectations, and do we actually have the right things in place to make those changes feasible? Next. So again, we just see these two tools as really complementary. So starting with private sector counts as a way to look at the past and do some comparisons across countries, and then moving to the FPMarket Analyzer to do that deeper dive into a country and look into the future. With that, I'm going to hand it back to Sarah, who's going to talk to us about a few additional resources before we open up for questions.
Wonderful. Thanks so much, Michelle, for that excellent overview. Next slide, please. And next. So as you can see, we have some excellent resources available on the SHOPSPlus website. All of these are compiled at SHOPSPlusproject.org. As you see at the bottom of the site, at /sources family planning materials. So at that website, you can see both of these links to both of these interactive data visualization websites, privatesectorcounts.org and FPMarketAnalyzer.org. We also have a cross-country brief that summarizes sources for family planning and gives an overview as to what's happening across the 36 countries that we studied in private sector counts. Next. We also have a suite of country-specific briefs, and these are very short 4-page overviews of what sources look like in each of 21 countries that have recent DHSs. And we look there, we break it down by all of the sociodemographic characteristics that we talked about here, and look at recent trends. And we collaborated with country stakeholders to write an implication section for each country about kind of what that means within the country context. Please check out our suite of resources as well as these tools. And at any point, please ensure we have, I think, a reasonable time for discussion. I'm going to turn this back over to Jason to moderate that discussion. Please continue to type your messages in the chat box at any time. Thank you. Jason, back to you.
Thanks, Sarah, and thanks, Michelle, for a great overview of these two tools, and really exciting and interesting to see these being used in country. And thanks, Michelle, for giving some examples. Okay, so we have a few questions. Some are short technical ones, and some are a little harder. Let's just start with a few clarification ones. And Sarah, can you distinguish in when you're talking about shops, we talk about informal drug shops and other types of shops? How do you distinguish these?
Thanks. That's a great question. So we are just to remind everybody, we're relying on women's reports of where they got their contraceptive method the last time. And so women can report that they got their method from a PPMV or from a proprietary patent medical vendor, or an ADO, an accredited drug dispensing outlet, which we would classify as a drug shop. And so all of the sources come directly from women's reports and as they're captured in the demographic and health surveys. So an ADO, a PPMV, or anything that was reported as a drug shop would be captured as a drug shop, versus if women said they went to a pharmacy, that would be classified as a pharmacy.
Thanks, Sarah. And I suppose while we're on the topic of clarifying these, maybe for Michelle, within the private sector, or this could be for Sarah as well, in the private sector, are we able to distinguish between for-profit and non-profit private sector providers?
We are to some degree, but I would say that it varies a bit by country. Again, we're limited by the responses that women kind of give within a DHS survey. In some countries, you're able to identify certain private providers as NGOs or nonprofits, especially where you have big, well-known networks that have name recognition, and those are included within the DHS. But other times, women might just say, I went to a private clinic, and you're not able to necessarily know that. And so we do, within both of our tools, sort of pull out NGO and faith-based organizations as a separate set, but that is often quite small. And so it might be small because that is a small sector within a country, or it might be small because a lot of women aren't just able to kind of identify the detail of their source in that way.
Thanks, Michelle. So those were the easy questions. Maybe a big and hard question that I think is on a lot of people's minds is the impact of COVID changes. And you're talking about looking forward and trying to forecast. Can you say a word about COVID changes and what's captured or not captured? Both, I guess, Sarah, in the private sector counts data, and Michelle in the ability to forecast here. I'll start with maybe Sarah, just to clarify on when the data come from for the private sector counts, and then maybe to Michelle for the forecasting question.
Yeah. So it will be really interesting to see how these results change with COVID. To be clear, these data come from the most recent demographic and health survey, all of which were conducted pre-COVID. So, and as we know, as some of us are very familiar with, almost all fieldwork activities that include face-to-face interviewing, which include DHSs, are on hold right now for safety reasons. And so we won't have new data for some time. So right now we can anticipate what might happen, and I hope that Michelle can speak to that a little bit, especially given that we know that some women are relying more on self-care methods that can be acquired within social distancing, such as pills and condoms. But the data that we're presenting do not yet show the impact of COVID. We'll update with the latest data when we have that available.
So the FPMarket Analyzer itself is not picking up these changes for COVID, right? So it's using projections of changes in contraceptive prevalence that were done before our current scenario. And so it's sort of looking at the growth that was already happening. As others have alluded to, we know that there are risks that those trends, that the progress that countries were making might not be being made right now. Because of disruptions due to COVID. So while these models don't capture that, there is other work out there that does. And so we're happy to point people to some resources. There's a tool that I and some others have been working on with the Reproductive Health Supplies Coalition and the GFF that I can send a link to, that's trying to look much more short term at what some of these changes might mean, especially if we do see these patterns of women sort of moving away from methods that require that provider interaction, like implants and injectables, to more self-care methods. And I think a key thing that we all are thinking about and should be thinking about right now are, the implications of that in terms of more women moving to the private sector on affordability and accessibility, and making sure that women are still able to access contraceptives without out-of-pocket payments becoming a barrier if their options are shifting right now because of COVID.
Thanks, Sarah and Michelle. So Michelle, that brings up a point. So if this isn't the right tool for looking at the current pandemic and its changes, you did allude to the FPMarket Analyzer being used in countries to assess the total market approach. Could you say a little bit, maybe a little deeper word about how countries have used the tool and some of the decisions or planning that they might have done based on that?
Sure. So we have a great example from work with colleagues in Tanzania. And we actually have a blog post coming out very soon that we'll share around with everyone that documents this experience. So Tanzania had a long history with having social marketing within their family planning program. And I've seen there's been some other questions about, recognizing that there are donor-supported commodities in the private sector, which is a very important dynamic to be thinking about. And there was starting to be some discussions about maybe sort of phasing out that support for the social marketing of both injectables as well as pills. And so we use the FPMarket Analyzer to look at some different scenarios of what might happen. And especially if you have women who were accessing these subsidized products in the private sector who weren't able to afford a commercial product, and they sort of shifted back to the public sector, we are able to then quantify what that additional burden would be on the public sector, which helped the stakeholders really move the discussion to talk about why that social marketing piece was so important and why it was so important to still think about how do you continue to make sure that you have this range of both commercial and subsidized products within the private sector. We found that, again, as I said before, rather than these theoretical conversations about what might happen, being able to put actual numbers to it and talk about, this many 100,000 women might now shift back to public providers for their injectables was really able to help move the needle in those discussions.
Thanks, Michelle. So I think we have time for maybe one last question, and there's sort of a large question here from a colleague about about wealth and the public-private sector mix. And here, they articulate the question as that providing urban women with contraceptive services through the private sector sounds feasible, but what about the lower wealth quintiles? And does this increase the out-of-pocket expenditure? So maybe we can turn to both Sarah and Michelle to provide some insight on this question and any last thoughts. Sarah, go ahead.
Thanks. Thanks to our colleague for this great question. So when we think about the private sector, we often think about for-profit private sector. But as Michelle mentioned, there's also a lot of nonprofit and subsidized private sector commodities and supplies and services out there. So for example, when we think about social marketing, many social marketing groups have, for example, condoms and pills that are subsidized, that are available in lots of drug shops and pharmacies at prices that are designed to be affordable for the vast majority of the population. And the goal of that is to help increase access and availability of methods to everyone in the population, whether they're urban and wealthy or rural and poor, because the most subsidized products are designed to be made to be set at price points that that many people can afford them. So I think part of the answer there is that the private sector is not one monolith, and we're not just talking about for-profit, but we're also talking about non-governmental and faith-based organizations, and even within for-profit outlets like pharmacies and drug shops, we are sometimes talking about subsidized products as well. And then I'll pass it to Michelle, who I think has a couple of great points to make.
Yeah, so I would just add, I think one, right, is that just because something's in the private sector doesn't necessarily mean that the burden to pay is on the client. We see that addressed through things like subsidized products, but also more and more we see that addressed through other types of financing mechanisms, especially as countries talk about things like universal health coverage, as health insurance schemes are increasing. There are lots of different ways that women could go to private providers, but not necessarily be paying for that service out of pocket, right? So we have things like vouchers, we have things like contracting out of services, where the government is actually reimbursing private providers for providing services, different health insurance schemes. And so I think more and more as we look to thinking about sort of universal access and everyone having access, that we're finding ways to kind of use the benefits of the private sector in terms of their ability to reach certain women, right? You might have a lot of private facilities in your urban areas, or you might have, efficiencies that can be gained out of scaling your private sector providers, but doing that in a way that doesn't put that out-of-pocket burden on women to ultimately get to those services.
Well, thanks, Sarah, and thanks, Michelle, for a great webinar today, giving us further insights into the private sector and public sector distribution of services and commodities in country. These are great new tools that are giving us greater visibility into what sometimes we just think of as contraceptive services in a country, but obviously are a mix of service provision through a host of different providers. I encourage everyone to explore these tools, to ask questions of our colleagues from the SHOPSPlus project, who are here to, I'm sure, answer further and more in-depth questions as you're starting to use the tools. So thank you both to the SHOPSPlus and FP2020 logistics teams, and of course to Sarah and Michelle and all the colleagues who do an immense amount of work to put together these tools. I hope that that you got something from this, something new, and that you'll use these tools for your future decision making. So a little round of applause for my whole team and all of the colleagues, and thank you. Hope you have a good evening, good afternoon, and a good day. Bye, thanks.
Thanks, everyone.
Thanks, everyone.